Well, thank you, sir, and I would like to thank the AIOS for this opportunity. And essentially, I'll be talking about femtosecond laser assisted keratoplasty and try to remove some of the myths around it. So we know that femtosecond lasers, we are used to seeing them, getting people getting LASIK done or for intacs. But there is another very useful way in which the femtosecond lasers can be used, and this is to perform the keratoplasty. So basically, we have three cuts at our disposal. One is called the posterior side cut, one is the ring lamellar cut, and the third is the anterior side cut. And once we stack these three cuts together, we can use that to create various patterns. For example, this is the very popular top hat configuration, or we can use it to form a Christmas tree configuration, or there's another configuration known as tongue in groove configuration, or which is my favorite, is the mushroom shaped configuration, right? So what are the advantages? Why do we want to make these shapes? One, that the femtosecond laser gives a very precise cut, and there is no other means by which we can actually shape the cornea like a mushroom. So this leads to a very smooth graft-host transition, also along with an improved wound tensile strength, and also it is possible for us to remove the sutures very early. Now this is what the machine looks like. Basically, we have to be very careful while we are entering data at what depth we want the cuts and what is the size of the cuts. So there is a space for ring lamellar cut and posterior side cut and anterior side cut. You have to feed the parameters. In this case, this is an indigenous artificial anterior chamber. Nowadays, I use Moria's artificial chamber also. And what happens basically is you appronate the cornea after fitting it on the artificial anterior chamber, and you can see by the generation of bubbles that the cut starts from the posterior side and then it proceeds to the anterior side. So the cut is starting here. We can see the ring lamellar cut is happening from outside to in. Posterior side cut has already taken place. Now the depth of this cut is usually between 50 to 70% of the corneal depth. This depends on the surgeon preference, what is happening. And this is then followed by the anterior side cut. So in this case, I am performing a mushroom shaped graft in a patient of keratoconus. So after marking the center of the cornea in the recipient eye, we have to appronate. The patient is of course blocked because it's not possible to block the patient after this is done. So again, we can see this generation of bubbles because this cut starts at a level of beyond the maximum pachymetry of the cornea. And this is followed by the ring lamellar cut, and this is then followed by the anterior side cut. So these parameters, disparity, some people keep a 0.25 disparity. This was a patient of keratoconus, and the parameters remained the same in the donor and the recipient graft. Now what happens is that we very gently, using a Sinskey hook or some kind of a blunt instrument, we have to just kind of separate out the tissue. It doesn't require much force, and we should not actually overuse the force, because if you overuse it, you will create a kind of a lamellar pocket into the donor lenticule. This is not desirable. Sometimes just few strands are left and we can just cut them with the scissors instead of trying to pull too much on them. Now when we come to the recipient eye, it's just like sometimes possible just to strip it off. It depends on what energy you have used, and pupil should be pilocarbonised just to avoid any damage to the lenticular surface. And viscoelastic is being used, and then suturing is carried out. Now, if you see the sutures, we say 90% depth, but not so in femtosecond keratoplasty. So it has to be with around the ring lamellar cut that we suture, and the surgery is completed. So we see, so there are certain issues with penetrating keratoplasty where flak overscores, because we need, there's an anterior-posterior and a rotational misalignment of the tissue. There's excess and uneven suture tension. There's a weak cornea. There's a slow and asymmetric wound healing, and there's a need for tight sutures. And all of this, they bring down actually the quality of outcomes that we want in these patients. On the other hand, with the femtosecond laser, very precise cut, and it's a customized cut. We have a greater accuracy of wound construction. We can plan multiplanar incisions, and tight sutures are not required. And what I've seen is we can go in for a fairly early suture removal, because this is a fibrosis along the edge. the cornea is much more thicker. My experience I wanted to share, especially in patients with thin and ectatic corneas, where all these issues are more magnified, and especially the issue of high post PK astigmatism, and we have to apply tight sutures. Sometimes there's a leakage from the sutures. In this case, the central pachymetry was 247 microns, and it's a very thin ectatic cornea. Patient was contact lens intolerant, and when we performed this surgery, and the post-operative refraction was minus 3.5 with minus 1.5 cylinder. And the difference of keratometry, pre-operative versus post-operative, was to the tune of 20 diopters. And if we see this, see how beautifully the graft and host junction is opposed. And not only the anterior surface, but also the posterior surface of the graft is very well opposed. And the pentacam also showed that the visual results were very good in this patient. Similarly, a post-hydrops eye, we can see the scar of the hydrops also, again 76 micron cornea, and we can see that post-operatively the patient is just having minus 3 with minus 3.5 cylinder. And if the pachymetry allows, we can even polish it and improve the vision using a topo-guided PRK or something like that. Similarly, a 127 micron cornea, very, very thin cornea. So these are so challenging when it comes to doing a routine OPK. But because we are giving that little collar around the graft, it significantly strengthens the cornea and gives great visual results in these patients, not only the anterior but the posterior surface. And in this case also the improvement in keratometry was 23 diopters, and sutures could be removed as early as 5 months in these patients. We can also use it to perform lamellar keratoplasty in these patients, and the CDK or other indications the patients do fairly well in these scenarios. So what I've shown is that FLAC offers very distinct advantages, but it is not meant for all conditions. Wherever the cornea is hazy to edematous, where it might not penetrate, then FLACS is probably not the way out, and we have to resort to the routine keratoplasty. Thank you very much.
Thank you, Amit. Lovely presentation and nice animation to understand the FLACS.